Does anybody need calipers, by the way? Okay, so come get them. That's okay. Doesn't bother me. Anybody need the handout? Because you'll be needing that as well. Does everybody remember the handout? Okay, so dig that out as well, please. So before we start, we're going to be talking about atrial rhythms today, and
cheat sheet cake.
so we talked about this last week, and it's possible we don't need this slide, but I tossed it in just to make sure everybody was in the same page on this. So Koa, what does the P wave represent?
Atrial polarization.
Good. And Andrew, what about the T wave?
Ventricular repolarization.
Good. So if you think about it, if things start in a sinus rhythm, for example, if things start getting really fast, the ventricles can be repolarizing, and if things are going fast enough, the atria will already be depolarizing. And there's nothing wrong with this. With a fast sinus tachycardia, that's just what happens. But it can make the ECG strip a little more difficult to read because exactly as you see on this strip here is that you can see here the P wave is started to move a little bit closer to the T wave, and you can't see either this end of the T wave or the back end of the T wave gets deformed, and the front end of the P wave gets deformed as they move together. And then here it's even more pronounced, where the P wave in this case is really just a little bump off the back of the T wave. And you don't have to do this at all. There's no particular reason. The thing is, if you wanted to be very precise about the PR interval, which in our case we don't need precision, we just need to know whether it's between 3 and 5 small boxes. But if you think about, suppose you did want to know the exact measurement of the PR interval, you'd actually have to draw the line down till it hit the isoelectric line. If you wanted to be that precise. For our purposes, that doesn't matter. But I'm just mentioning that so you understand what you're seeing. And the logical conclusion to that, and it does happen, if it gets fast enough, if the rate gets fast enough, what do you think happens? If it keeps moving together, the QRS is moving together.
Small, right?
Let's see, I think I heard the correct mutter over here.
Well, they'll kind of just get buried in the
Yeah,
P wave.
in fact, the P waves will completely disappear because they'll just move right into the T wave, okay? So that's just a handy thing to know, and we're going to need to know that today. So I'm just pointing that out. So today, it's the start of this lecture. I've purposefully broken it into 2 pieces. Today and then next week, primarily because it's just so long. If we did it all in one stretch, we'd all of us be fast asleep. So it makes sense to break into 2 pieces. So we're going to start today by talking about premature and escape beats. Then we're going to talk about re-entry circuits. We're going to do a little introduction of something called SVT, which we're going to pick up again here. And then we're going to do atrial rhythms. And that's where we'll stop today, at least that's my thought, is between atrial and junctional. And then next week we'll do the bottom half here. So let's start with premature beats. Do you remember when we were talking last week with the 5-step process, and we talked about whether something was regular or irregular, and we started by saying if it's irregular, how in fact is it irregular? And one of the reasons was that the underlying rhythm is regular, made irregular by what I was calling oddball beats, okay? So now we're gonna be a little more precise. Rather than saying oddball beats, we're gonna come up with what they really are. And most oddball beats, again, that's just my term, are some form of premature early beats. Now, to understand premature beats, we have to go back to a phrase that we talked about last week. So, Spencer, do you remember what the phrase ectopic focus means?
No.
Do you remember ectopic? Is that?
I do remember it. It wasn't, I don't remember folks, I remember it being foci.
Yeah, that's the plural.
Right,
Yes,
and then,
good.
And then
Okay.
you said that we were gonna talk about that a lot.
And
then
here we are.
and
I
then here we
I
are,
wasn't
don't know.
lying. Okay. Okay, you remember a lot of things. Riley, do you remember ectopic? Do you remember what that means?
No, I do not, I'm sorry.
Go on.
Topic is abnormal or outsides, and then focus was the pacemaker. So if it's outside, it's abnormal.
Yeah.
Inside, it missed.
Yeah. So it's where the impulse is coming from, the pacemaker, and ectopic means misplaced. So Andrew, do you remember I said there's only one place in the heart where the pacemaker is considered not misplaced, not ectopic? Where's the one normal, healthy place for the pacemaker to be in the heart? SA node. So, I mean, it may be a good thing that the pacemaker has moved to the AV node. So, for example, if the SA node poops out on us for some reason, it's a good thing that there are other parts of the heart that, you know, pick up the slack, if you will. But they're still considered misplaced. They're still considered ectopic. So the only place in the heart that is not where a pacemaker is not considered an ectopic focus is the SA node. Every other place is considered ectopic, is misplaced. So ectopic foci, and yes, foci is the plural focus, are abnormal pacemaker sites within the heart that display automaticity. An ectopic focus can be anywhere outside of the SA node. Okay, so of course the heart has the ability to, to have automaticity outside of the SA node, but that term ectopic focus is used to apply to anywhere except the SA node. Again, that doesn't mean it's a bad thing necessarily. It's just descriptive. It's just describing misplaced. Any place outside of the SA node is considered misplaced. Okay. So now, here's where it does get a little bad. An ectopic focus, so you need to know what ectopic focus is because we'll be using it all the time. The other term that you'll need to know is irritable, okay? And that is a formal term. That's not one I made up. Is an ectopic focus. So for example, here we have an ectopic focus. Why is this ectopic? Well, it's in the atria outside of the SA node, so that's misplaced. This little real estate of the heart is considered irritable if for some reasons conditions push this little place on the heart closer to threshold potential, closer to automaticity, to firing off its own pacemaker. Okay, so this would be irritable if it's more likely to fire off. So what do you think? What are some conditions that might make that that ectopic focus irritable? What would you think? Yeah, hypoxia, great. Okay, so here's a couple of them. Increased sympathetic stimulation pushes everything toward threshold potential. Ischemia, so hypoxia leading to ischemia. Electrolyte imbalances and stimulant drugs. So really the usual suspects, okay? So what that means is if part of the heart is becoming ischemic, it's far more likely to start firing off and not waiting for the SA node to do so. Now, so here's what happens. We'll go back. Here's our SA node again. I'm not bothering with P waves. They should be there. These are just beats, and everything's going fine, nice regular rhythm. And then what happens is some part of the heart becomes irritable. We don't know why precisely in this example, but we could think, oh, maybe there's some ischemia, or maybe this person is taking some kind of stimulant drug, okay? Now, the irritable ectopic focus can be anywhere that's considered ectopic. So it can be in the atria, it can be in the AV node, or it can be in the ventricles. In this picture, it's just sort of in a general spot, okay? Now, what happens is the SA node with a premature beat, remember the whole point of this is we're describing the mechanism of a premature beat, is the SA node is just firing off, nice, regular, and so forth. But this little spot here is becoming more and more irritable, more likely to fire off. And all of a sudden it does, maybe only once. It fires off, and just for a moment, it grabs control of the heart and depolarizes, whatever, it depends on which part of the heart it's in, but it starts the depolarization. So this is how it works, is the SA node's firing off, no problem, no problem, no problem, but the irritable focus all of a sudden becomes so irritable that it fires off anyway. Even though the SA node is doing its job, this irritable focus says, oh no, I can't wait anymore, I've got to fire off, and just for a moment it grabs control of the heart and there's a premature beat, okay? So, but the SA node then goes back to doing its job. And so remember when we talked about, well, how is it that sometimes a strip is not regular, that it's irregular, is that the underlying rhythm is regular, made irregular, in this case by a premature beat, okay? So, Grace, if you could just scan across here and point, I will tell you there are 2 premature beats here. Where are they? So it's where you're going to see it. And I think you can see it. I think you can see it without your calipers. Just, yeah, there you go. Good. And there's the other. Exactly. And so you can see, here's the normal R to R interval. Okay, right? But all of a sudden there's one that comes in short. So if you have your calipers and you're marching it across, oh, that one's short. This one's long because it takes a moment for the SA node this particular premature beat, in fact, kind of demolishes. The SA node would be firing off here, but this premature beat depolarizes everything. So even if the SA node is actually firing off, nothing responds because it's already been depolarized by the ectopic focus. Does that make sense? So then the SA node comes back in, that irritable focus, oh, it really wants to fire off, and it does it again, grabs control of the heart just for 1 beat, or sometimes 2 beats, and then it goes back to the underlying rhythm. Yes, please.
I'm just curious as to why the amplitude on those premature beats is smaller than the ones that are part of the regular phase.
Well, they are not always, but in this particular case, and in a while you'll know why I'm saying that. Let's see, why would they be? I thought I had the answer, now I'm thinking. So this is an atrial premature beat. The ectopic focus is in the atria, and you'll learn about that pretty quickly. Let me get back with you. I think I know the answer, but I'm not entirely sure. So, okay. Now, there is another far less common kind of oddball beats called escape beats. Premature beats are far more common, but every once in a while you're going to see an escape beat. And there's a difference, okay? So by definition, Natalie, does a premature beat, does it come in too early or too late?
Too early.
Yeah, by definition, what's happening is you have an irritable focus that's just waiting to fire off, can't stand it, grabs control of the heart too early. That's what a premature beat is. An escape beat is a little bit different. With an escape beat, what happens is the SA node is firing off just fine, everything's going well, okay? And then something goes wrong. There's some kind of sinus pause or sinus block, and the SA node just stops for a moment, okay? Now think about it, if you're, the rest of the heart, if the SA node is not firing off, what's going to happen in the rest of the heart? Let's say the SA node just stops forever. What's going to happen in the rest of the heart?
Well, the AV node's still
Yeah,
by the heart.
so in other words, the rest of the heart becomes irritable. So it becomes irritable because there's this pause and it's saying, wait a minute, I'm waiting for the SA node, but the SA node has gone away, so I guess I have to take over, I have to fire off, okay? The irritable focus can be anywhere. So in this case, what happens with an escape beat is there is there's a depolarization that comes from another spot. It's an ectopic focus. And then, because in the case of an escape beat, by definition, there's usually only one or two, the SA node comes back. So we know why this happens. Perhaps it's a long sinus pause, or perhaps it's a sinus arrest. And the rest of the heart becomes irritable until someplace in the heart, some ectopic focus will fire off, okay? So if you look here, so you can see here, this is not coming in prematurely. So in this particular case, it may just be that this sinus brady is so slow that the rest of the heart can't stand it and it starts firing off. But it only fires off one and then the brady picks up again. Okay? So it's a subtle difference, but it's there. Yeah.
So for both premature beats and escape beats, they're regularly irregular?
Well, so first of all, let me be clear about one thing. The terms regular and irregular are for you to use as you see fit. So don't feel like I'm going to say on the test, is this regularly irregular or irregularly regular? I'm just not going to do that. So you don't have to learn it for me. You have to learn it for your use.
Okay.
So for me, the way that I think about it is like, let's go back. In this particular case, the way I like to think about it is the underlying rhythm actually is regular, but the overall strip is made irregular because there's two premature beats. So, that's what's happening.
But they're gonna come in at the same time each time, so it's like every 3, there's one.
Oh, I see. Yeah, then you could say, yes. So if the premature beat does hit a regular pattern, sometimes it does, sometimes it doesn't, then you could say it's regularly irregular,
So it
definitely.
won't always fire at the exact same time. I guess that's my question. It's gonna like fire.
Well,
sometimes the same time, sometimes-
as you're going to see when we do premature beats, there's all kinds of patterns.
Okay.
So one not common but not rare pattern is one where it's every other beat. And that's common enough that we have a term for that called bigeminy. And sometimes it's every third beat, this is every fourth beat, and we would call it trigeminy, So there is, but even if you have bigeminy or trigeminy where it's every second, every third, whatever it is, there's no rule that says it has to be like that, so maybe it'll go through a patch where it becomes irregular. So you'll see everything.
Thank you.
Yeah,
The QRS on the the escape beat.
yes,
So that means that the ectopic foci is in the ventricle? because
Yes.
of the okay.
that's correct. And that's not, that's a great comment if the rest of you are thinking, what? Don't worry about it, because we will get to it. Today we're going to get to premature atrial beats, but in fact that is a premature ventricular beat. Okay, but don't worry about it. If that's for anybody else. If you understand what he's saying, great. If not, you'll learn it when we get to it. Okay, in summary, premature beats versus escape beats. Now pay attention, because in a minute you're going to be doing a handout where you're going to be looking at this. With premature beats, the ectopic focus is already irritable, hypoxia, cocaine, something like that. And so it depolarizes early, grabs control of the heart for a moment or two, causing a premature beat. With escape beats, the ectopic focus becomes irritable because of a pause in the underlying rhythm. And then the escape beat depolarizes late. So what you want to do is, let's see, I think first of all, let's real quick turn to page 15 so I can explain what's there, and then we'll go to page 16. So as I said, on page 15 you'll see an outline of this lecture, this and next week's lecture. It's just there for your own use. It might be useful for studying or just seeing where we're at. With these long lectures, I think it's kind of handy to have a little outline so you know where you are. But what I want you to do now is go to handout number 1, which is page 16, page 17, and page 18. So 1 through 13. And what you're going to do is, first of all, identify the rhythm. They're all going to be, there's normal sinus, sinus brady, sinus tach, so it's good practice. And are there any ectopic beats, okay? If so, are they premature beats or escape beats? You can do it by yourself or with your neighbor, doesn't matter to me.
Take a quiz.
Okay, so who's got the pointer? Okay, Natalie, I think you do. Okay, so let's start off, and I'm going to walk you through this one because we're just kind of starting. And there's 2 jobs here, and I think we haven't done enough of the first one. I think that's partly what's screwing you up. Is that I want you to identify the underlying rhythm first, okay? Now, a suggestion to you, when you have, and this is a great idea throughout all your ECG recognition, over and over again, you're going to have a strip where most of it makes total sense, and then there's something weird happening in part of it. In this particular case, a lot of the weirdness has to do with ectopic beats, extra beats, okay? It's always a good idea when you're confused by a certain part of the strip, just don't look at it for a few moments. Look at the part that makes sense to you, which is usually, not always, but usually the underlying rhythm. Identify the underlying rhythm, you're halfway home, then go back and get the weirdness out of the way, okay? Mm-hmm. So, where do you see the ordinary stuff and where do you see the weird stuff?
Oh, this is ordinary, and then this is ordinary, and then this is going to be a weird beat.
Perfect, perfect, okay. So what do you think about the ordinary stuff, the underlying rhythm?
I thought it was pretty normal, and then I used like
Normal meaning regular?
Yes.
Okay.
Regular upright P's and T's,
Okay,
and then I used the 300, 150 method.
and what'd you come up with?
I got like around 90 beats per minute.
Okay.
So it'd be a sinus.
And what was the PRI? As long as we're doing it, we might as well do the whole
That's a
5-step
good
process.
question. I didn't do that. PRI is 3 to 5, so
Uh-huh.
be from here to here, and that is less than 5.
Yeah, so we're good.
And the QRS is less than 3. So,
Okay,
yeah.
so,
So I said it was a normal sinus rhythm.
Good.
With a premature beat.
okay, and where's the premature beat?
Right here.
Okay, so, and again, if you're thinking, you know, when you march it out, to see the regularity, you pick up your calipers and you're marching, okay, that's good, that's good, that's good, that's good, that's good. Oh, that one comes in early. A good suggestion at that point, especially when you're just starting off, is take pencil, whatever, and, you know, and circle it. That's the weird one, okay? And then you can move along, so you know you can come back to that, So if I were to ask you, what do you see here, the answer would be a normal sinus rhythm with a premature beat. Pretty soon, in fact, later today, we're going to start identifying what kind of premature beat. But for now, all we're saying is either premature beat or escape beat. Okay? So any questions? Is there anybody here who doesn't see the normal sinus, doesn't see the premature beat? Any questions about it? Okay, good job. Okay, you can pass the pointer on to either Cody or Grace, whichever direction you want to go.
Grace,
I got it.
So this
You all
one
get a chance, don't worry.
is,
Okay.
I got sinus tachycardia.
What's the rate there?
Look at me like
So let's say you did the boxes method
Yeah, I
from this
didn't
one.
do it, I just kinda eyeballed it.
Don't eyeball, okay? Because the difference is between sinus tach and normal sinus can just be 10 beats a minute, and you can't eyeball that much.
Alright, let me.
So
not
if
eyeball
we
it.
start here, this is a pretty good one, then what's our first number?
I'm gonna say 90.
Okay, so is that a sinus tach?
Yep, so we got, no,
What's
sorry, sinus normal, sinus normal.
what's our definition of
Sinus
sinus tach?
normal. 60 to 100,
Okay,
over 100.
okay, so sinus tach?
Yep, no.
No, okay.
You're throwing trick questions.
Sinus
normal.
You've got a long
I
year
said-
ahead of you if you think that's a trick question.
60 to 100.
I said it.
We're
Okay.
gonna code the percentage.
Normal.
It's all good, it's all good.
It's a normal
Yeah.
beat, I'm never doing this again.
Actually, you will, but.
And there's
that's
a
okay.
premature.
Okay, where are they?
So much question.
Right there.
Any others?
I guess the one before.
Okay,
Yep.
yep.
Conviction.
Yep.
Yeah,
Check.
yeah, okay, so how do you know, hey Cody, how do you know if it's premature? Using your calipers, how do you know?
Because it's, the QRS complex is more narrow in those ones compared to the other ones.
Say it again?
R to R, there we go.
Okay, so, what I want you to do, I just wanna make sure you've got this, is that, if you start off and you find, oh, here's the regular R to R interval, then what you're gonna do is this one comes in early and this one comes in early, okay? So, we all do this, like we eyeball things, and many times it works totally fine, until it doesn't. So you really want to, especially when you're just starting off, make a habit of using your calipers, and then as you develop your ability to just see things, you don't have to use them quite as much. Okay, so normal sinus with 2 premature beats. Any questions? Okay. Chris, what do you think of this one?
For this one, it's just barely normal sinus. It's like teetering on 60 beats
Okay.
a minute.
Yeah, I see what you mean. Okay, so you can either say borderline sinus or 80. Yeah, I totally agree with you.
And then it's an escape beat.
What is the escape beat?
I think it's an escape beat. Right here where there's that giant pause.
Okay. Now, what's another possibility of what it could be?
Block RS.
I heard the correct mutter over here. Say it again?
Sinus block.
Yeah, it could also be a sinus block. Now, how are we going to know, okay, what it is, okay? So in this particular case, what I would do is find your R to R. And if this one is exactly this, or close enough to the same by our definition of within 5 small boxes at this rate, then it's just a sinus block. It's not a true escape beat. Okay, so with an escape beat, it's going to come in, there's going to be something about it that's out of rhythm. It's either going to look, the other thing is it doesn't look like an ectopic focus, meaning that this beat, this P wave, this QRS, this T wave looks precise pretty precisely like the other ones. And so in that particular case, it doesn't make sense that it's coming from a different part of the heart, it's a little bit different.
So a real escape beat's always gonna look different somewhere in the.
Yes.
Okay.
So,
Yes.
so number 4, it looks like we have a sinus block, but since that QRS complex looks really different from the other ones,
Yes,
that's an escape.
correct,
Okay.
correct. So, so again, I do use trick questions. I'm trying to trick you all the time, meaning that, so, you know, you got the true trick question because you were expecting either an escape beat or, and a premature beat. But you've got to keep factoring in what you already know, okay? Okay, Spencer, since you already told us the answer on 4, why don't you go ahead and do it?
Okay. Totally do that. It. Okay, give me a second. So it looks like it's about 70 beats per minute.
Okay,
I used the 6-second method.
okay.
That's okay. So normal sinus.
Let me,
rhythm.
let me,
Yeah.
ask you how you use the 6-second method, because it's a little hard to use the 6-second method. You can,
Uh-huh.
if,
Just a little inconsistent.
like, for example, here, I think it's very reasonable to use the 6-second method on number 3, and I'll tell you why.
Yeah.
Is because, first of all, just remember, unfortunately, on some of these, here's my other, totally out. On some of these, I've cut off the 6-second marks, and my apologies for that. But you can always come in about 2 blocks and say, that's about where the 6 seconds are. Okay, got that? Now, in this particular case, I think it would be very reasonable to use the 6-second because I would go 10, 20, and then if I did my calipers here, I'd realize it was about twice. You know what I mean? There's 2 intervals there. So you could go 10, 20, 30, 40, 50, and then there's a little bit on either side.
So when
So
it's-
it's somewhere between 55 and
So it's
60.
pretty uniform, like.
This one, I think is kind of a hard one to use the 6-second because you're gonna have to calculate for the underlying rhythm,
Right.
this is 3 times as much and so forth. So I actually recommend, you came off pretty well, so, you know. you're
I just don't remember, I know it was 300,
Okay,
150,
so that's,
100, and then is it 90?
so what is it? 300, 150,
75.
100,
Okay, then
75?
it would have been somewhere around 70,
Yeah,
75
so
or
you
something,
actually-
because, yeah,
Okay,
yeah, whatever. Is there
Okay.
a number point or somewhere around here? So,
Okay.
okay. Sorry, I'm gonna get my money's worth here. Which button?
you just press.
Alright, so, I go 300, 150, 100, 75, you said?
Good,
So,
good, yeah.
So, boom, so 75, pretty straightforward.
Okay,
PRI interval is less than 5,
okay,
or the PRI is less than 5, QRS is less than 3, and so it's a normal sinus. And then that would be an escape beat,
okay.
because it looks different from the other ones.
And also,
QRS
how does it come in, early or late?
Late.
Yeah,
right?
so this is a
Sure.
really classic escape
Right.
beat,
Okay.
okay? Now, somebody explain again, what's the difference in the mechanism, the underlying mechanism between an escape beat and a premature beat? Why does one happen, why does the other one happen? Yeah, Andrew,
An escape beat happens when the heart's SA node doesn't fire, so the ectopic focus then is irritable. and so
Okay.
it fires, and a premature is just where the heart gets stimulated
okay.
too early.
Okay, so in one, it's already irritable, the premature beat. The other one, it's made irritable by this pause here. Okay? Okay. So let's go back. I think, Kyle, you were supposed to be next, and I gave yours to Spencer, but here you go, number 5.
Number 5, I had this written down as sinus tach at give or take 120 beats a minute.
Okay.
With a premature beat at ABC right there.
Okay. And where's the other one?
Oh, the other one right there.
Okay, yeah, okay. So, sinus tach and, yeah, so questions about that? Sinus tachycardia with 2 premature beats, yeah.
Why are these QRSs so much larger?
So the shape of the QRS is really dependent, remember when we said an ectopic focus can come from anywhere in the heart. It can come, like the oddball beat, the premature beat can come from the atria, premature atrial beat, the AV node, premature junctional beat, or the ventricles, premature ventricular beat. And what we have not done yet is talk about how you can tell, say, a premature atrial beat from a premature ventricular beat. And a lot of that, not entirely, but a lot of that has to do with the shape of the QRS. So in this case, we're actually not going to get to this for another 2 weeks. But in this case, it's a wider QRS, so it's going to be a premature ventricular beat. But for now, you don't need to know that yet. A couple weeks you will, but for now we're just recognizing it as sort of a generalized premature beat. Okay, so Riley, you're next, and this one is sort of irritating, but do your best.
Yeah, I'm working it out as we speak. Let's see. So these are calipers going from R wave to R wave. Even though the QRS on the third QRS looks super wonky, but it's consistent as far as.
It comes in right on time, and
Yeah, it
I've
does.
said
Yeah.
earlier late, I haven't given you the scenario for.
Yeah.
So another way to think of it is like this. And then in a minute, we'll talk about why this one is particularly like this. Think of a premature beat that comes in early, and an escape beat comes in not early.
Okay.
So that you can include things that come in right on time, in other words, as this one does,
So.
for an escape beat.
Oh, I see what you're saying. So, wait, I'm sorry, can you explain that one more time, please?
Okay,
How'd you say that?
so let's do this.
Mhm.
What's the underlying rhythm? Let's start with that.
A great card.
What kind of bradycardia?
Sinus.
Yeah, that's the
Yeah,
only one we've
sinus
had so far.
Yeah.
So the underlying rhythm is a sinus brady,
Mhm.
okay? And then what's weird about this one is that the really strange looking beat, it doesn't look
Mhm.
anything like the sinus beats. It doesn't come in early, it doesn't come in late, it comes in pretty much right at the same time.
Right.
So it's still considered an escape beat, even though it doesn't come in late, because it doesn't come in early. And also, if you think about what's the underlying mechanism, what's the difference between a premature beat and an escape beat? In this case, this is really, really slow brady, so 10, 20, 30, it's like 35 or something. That's very slow. And so it's pretty easy to picture at a rate of sinus brady, a rate of 35, you don't need a pause for the rest of the heart to become irritable. Just that slow rate in and of itself makes the rest of the heart irritable because it's just not getting the perfusion it needs. Because it's so slow. I mean, you may find yourself at some point doing CPR on somebody who has a perfusing rate of 30 because it doesn't sustain long. So in this particular case, if you think of it like that, you can say, okay, and I'll give it away right now. Again, you don't need to know it, but this happens to be a ventricular beat, a ventricular escape beat. You don't need to know that. So what's happening is the ventricles are waiting, and they become irritable, but the sinus rhythm is so slow that it just throws out a beat, and to be honest, it's just coincidental that it comes in right where the other sinus beat should be. And in fact, the other sinus beat probably happens, you just can't see it because on the ECG strip it's engulfed, if you will, by the ventricle.
Do you think, well, I guess this probably goes into what a ventricular beat is, and I'm not trying to do that, but do you think later on down the road, this ventricular beat may not necessarily be kind of overwhelming the standard QRS, so it would be kind of off, it wouldn't be on time?
Oh, I see, if it happens again, yes,
Okay.
yeah, I mean, possible,
Yeah.
yes.
Because this brady is so slow that it's right around what the intrinsic rate of ventricles would be,
Yes,
Could this,
yes.
like, I feel like this is really treading between escape and premature, because it
Oh.
could be coming in a little bit early of what that sinus rhythm is.
Yeah,
But it's also that Brady's so slow that it could just be wanting to take over because it's going so slow.
yep. You know, everything you're saying is right, and in all honesty, we're splitting hairs, because, I still stand by the idea that again, if you think of what the real difference between premature and escape is not necessarily what you see on the ECG strip of the underlying mechanism. In this case, I'm pretty confident that in this case, the ventricles are made irritable because they're not receiving, the depolarization. But, you're right. If you want the honest truth, it's hard to find an ECG strip with an escape. They're much rarer than premature beats. And so I sort of stick that one in, and nobody notices all this stuff. But you guys did great. It's right. So I would call that a sinus Brady with an escape. Okay? Okay, Cohen, any questions about that? Did we get everything answered that needed to be answered? Okay. Number 7, please, Cohen.
7. I did the blocks method for heart
Uh-huh,
rate.
okay.
And I got around 58, 55.
Okay.
Using that method. I was also a little confused because I marched out. It marched out evenly with the R2R, but then the PRI
Is a little long?
is long.
Yeah,
and
so-
the PRS was borderline.
Okay, so, good observation, I'm glad you picked that up, because it shows you were doing it carefully. At this stage, we don't have the vocabulary to describe why this PR interval is a little bit long. So we're gonna ignore that and just go ahead and call it, what underlying rhythm did you call it, by the way?
I guess it'd be sinus, but I was just staring at the PRI.
Yeah, so I'll tell you now, that long PRI doesn't, even when we learn what it is, what it's gonna be, is first degree AV block, doesn't change the fact it's a sinus rhythm, okay? It's just a sinus rhythm with an AV block, but for now, we don't, that's not the focus here, although you're exactly right. So, underlying rhythm, we can call it, you're right on 60, so borderline sinus Brady, normal sinus Brady, it's all good. And then, what else?
So sinus, Brady, and then this would be the block, so sinus, block.
Yeah, good. So again, we're in the exact same situation as the one I think that Chris did, where it's not an escape beat because it just picks up again, pretty much just exactly the same. So it's just some kind of sinus block or sinus pause. So what I would call it is a borderline sinus Brady. Again, you can say normal sinus, it's right on the border, with a sinus block or a sinus pause. Okay, moving along.
So, 6-second method, I got 80 to 85 beats per minute.
Okay.
It's a sinus arrhythmia because I can't. My question is because so the 5th, 6th, and 7th, they're long. Their R to R's are longer than these ones.
Yeah.
So I don't know if it's an escape beat or if it was like the arrhythmia we talked about.
What was the difference in R to R's?
Three
Okay.
small boxes.
Okay,
So
so in that particular case, so first of all, am I sure that's not a sinus arrhythmia? No, I'm not. But let's go, it could be in fact, because I see how there's several that are longer and several that are shorter. Okay, and I think you picked that up last week as well, so that was good.
yeah, it seems like I
But
got
the
same
truth
exact ones.
is that I'm still gonna go with this. If you call it sinus arrhythmia, that's great. But I think it's not fair to call it a sinus arrhythmia if I'm only giving you 6 seconds. So I'm putting this up here as a normal sinus rhythm, particularly because the difference, I'm persuaded it's a sinus arrhythmia, not because the difference is significant. 3 small boxes is not, it's the fact that there seems to be a pattern to it. Okay? But, like I said, you can just use it as a rule of thumb on my test. Unless you get a really long strip, like more than 6 seconds, it's not gonna be sinus arrhythmia because it's too hard to see, okay? So, so let's go back.
Okay.
We'll call this a normal sinus rhythm,
Yep.
and any oddballs?
No.
No, this is just plain normal sinus rhythm. And I did the rate of about 80. Questions? Okay, next
Nope.
please.
Don't worry about
I am saying number 9 is normal sinus rhythm at about 80 beats per minute using the 300.
The boxes method, yeah.
Yeah, the boxes.
Yep.
And then we have a premature beat right here.
Yeah, excellent, good job.
Done.
Natalie?
Alright. I also like the boxes method, so I got about 95 beats per
Okay.
minute. And then I'm saying, we're on number 10 right now. This is the premature and that's premature. So
Okay.
normal
And
sinus.
normal sinus,
with
excellent.
premature.
And it's so close to 100 that if you put borderline sinus attack or sinus attack, I'm okay. But I agree with the 95. Okay, number 11, Cody, this one's yours.
So for number 11, I did the boxes method,
Okay?
and this one, I struggled doing the boxes method because there was not sort of a set lined up perfectly,
Right, I agree.
but I believe it was borderline sinus Brady.
Okay, so let's, this one's not working. So let's, in our mind, shift that one over, knowing that, I would do this one, but either one. So 300, 150, 100, 75. So it looks to me like right on 60, is that what you said?
Yeah, I
Yeah,
said borderline.
perfect, yeah, good.
And then, from here I struggled, I don't know, because, oh wait, hold on, I gotta measure. So, and that's, this one is a little long,
Which one?
this QRS
What do you mean the, oh,
is, sorry,
okay.
the R interval is long on this one.
So from here to here?
Yeah,
Okay.
compared to the rest.
What about this one?
Which one was it?
So here, we have an R to R, here we have an R to R, and here we have the third R to R interval. How does that compare to the first two?
It's a little shorter.
Okay,
by this
so it's a little bit short. And what else is notable about the fourth QRS, or the fourth beat? What's notable about this one? Like when you were doing your 5-step process, what did you notice
one. No,
about?
the P is inverted.
Excellent, okay. So this one's a little subtle, but if you put it all together, what you have is an R to R that's a little bit short, followed by an R to R that's a little bit long, and a P wave that's not a sinus P wave. So if you put that together, that's going to be a premature ectopic focus, okay? Let me go back a little bit and show you something on a more obvious one. Let's see.
What is our margin of error again? Is it 5 boxes? Is it
Well,
10?
on that one, it's probably about 3 boxes, and even, but hold on here, let me show you something. So Cody, on number 10, I know you did a different one, but on number 10, show us, you've got the pointer, where is the premature beat?
Right
There's
there.
that one, and then there's another one, where's the other one?
Looks like right there.
Okay, now, characteristic of a premature beat, we've already talked about the fact that it comes in prematurely, meaning that the R to R here is short. But there's another characteristic of a premature beat, is it's followed by an R to R interval that's too long. Because in fact, what's happening, think about it for a minute, the SA node fires off, it fires off, it fires off. The ectopic focus fires off, and depolarizes everything in the heart. So the SA node probably tries to fire off here. Who knows, it might even fire off, but it hits atria that are in the refractory period. So there's no sign of a P wave here, there's no sign of a QRS here. But by the time it fires off again, everything's ready to go. So you're going to see that over and over again, and that's a useful part of learning ECGs, is to get a repertoire of shapes in your head, a repertoire of patterns. And a very useful pattern is when you see a short R to R interval followed by a long R to R interval. Suspect, it's not always, but suspect a premature beat. Now, what makes the one that Cody did a little bit difficult is the fact that this one is short, but it's not tremendously short. This one is long, but it's not tremendously long. However, if you compare this one to that one, there's a big difference. It's a short one followed by a long one. And we might think, oh, could that be within normal limits? But then couple that with the fact that it originates from some place other than the SA node because it's got an inverted P wave, it's a premature beat. Okay? Does that make sense to everybody? Anybody want to argue? It's not argue, but anybody want to? It's everybody's solidly sure that that's a premature beat. Put it that way. Okay. Okay, next one, Chris.
So this is Science Tac, sitting
Good.
around 140-ish.
Okay, Nice.
And then it's going to be a premature beat as well, right here.
Excellent. Nice job. Okay, now notice in this one, I know that if I were just to glance at it, I'd just say sinus tac, nothing funny happening. So you really have to go through. And if you're actually taking your calipers and going through, oh, this one comes in early. Okay, so good job. Okay, final one. So, yeah, Ann, why don't you do it?
Okay, that was sinus rhythm around 70.
Okay,
And there are 2.
and where are they, please? Okay, and just remember, you might have said it and I might not have heard, when you have a sinus rhythm, you can say sinus at a rate of 80, that's fine, that tells you what it is. The other way to say that is normal sinus rhythm. Okay. Okay. So we'll go through re-entry circuits and then I think we'll take a little bit of a break. Okay. So, re-entry circuits. So, what are re-entry circuits? So, re-entry circuits are a group of cardiac cells, and group is purposefully vague. It can be a little group, it can be a big group of cardiac cells that depolarize in a circular pattern that is rapid and repetitive. It's also never considered a good thing. Okay, it's considered pathological in some cases, really bad pathological in other cases, not all that bad, but this is never considered normal. So what's happening is you have a group of cardiac cells that get stuck in this pattern of circulation that just goes extremely fast, round and round and round and round, okay? The reason we need to know about re-entry circuits is it's the underlying mechanisms for most tachydysrhythmias. Koa, can you tell us what does the term tachydysrhythmia mean?
So tachy would be faster than 100 beats per minute, and dysrhythmias are irregular.
Or bad?
Bad.
Can be regular. Can be regular. In fact, frequently if it's a re-entry circuit, it's going to be regular. So it's a bad fast rhythm. Okay, so the underlying mechanism of VTach, of SVT, of many of the bad tachycardic rhythms is re-entry circuits. Okay, now re-entry circuits can be large, involving large swaths of the heart, in which case the term, you would call those macro re-entry or macro entry, either one. Or they can be little tiny things, in which case they would be called microentry or micro-reentry. Okay. Now, I am very certain that nobody here in this room has a reentry circuit happening in their heart, okay? It's the underlying mechanism of most tachydysrhythmias, and we're going to spend, a lot of time in this class talking about those bad, fast rhythms, and pretty soon you're going to think they're everywhere. But the truth of the matter is they're not. There are not a whole lot of people in this building, if anybody, who is presently in a ventricular tachycardia, for example. These are not common things. It's just as paramedics, we get called to them or talk about them, and we start thinking they're common. The reason they are not common is because very specific special conditions are needed to establish a reentry circuit. So very specific special bad conditions. Remember, this is a bad thing, okay? Now, the next few slides, I'm going to go through what the special conditions are, and it's pretty complex. When we come to the end, I'm going to tell you what I want you to know, what I want you to get from it. So just hang in there as we go through this. So keep in mind, we need special conditions for this rapid circular pattern to develop, okay? So the first thing we need, the first most important, not necessarily most important, but the necessary prerequisite is that we have to have a little patch in the heart, or maybe a big patch, that is non-conducting tissue. Non-conducting tissue, why would that be? Well, there's a number of reasons. Suppose somebody had a previous infarction and they have a little piece of dead tissue in the heart. Then what they're going to have is a little part of the heart that doesn't conduct. Or maybe right at the moment that person is so ischemic or so hyperkalemic or something along those lines that part of a little piece of the tissue is either not conducting at all or conducting so slowly it's as though it's not conducting. So for now, just go with me and know that sometimes in the heart there will be these islands of non-conducting tissue, okay? And then what happens is, because it's like a rock in a stream or a river. Let's think of a river and it's got a big boulder in the middle. And the boulder is so big that the water can't go over it, it has to go around it. It's the same thing with the electrical conduction and the non-conducting tissue, is because like the boulder in the stream is there, it creates two pathways, if you will, around it of electrical current, okay? Now, if that's all there is, it's not really a problem. In fact, the person might not even notice it, because it's a little bit like if we use the rock in the stream analogy or the boulder in the river. If you're downstream and you have the river, even if it's a strong current and it goes around the rock, it comes back together, and if you're down here, you're not even going to realize that the rock's there. So if that's all we have, no problem, no reentry circuit, okay? Just not a big deal. So that's the first prerequisite. The second one is you have to have some sort of block or slowed conduction in one of the pathways. In other words, this is the electrical current, and it's just going to go fine down here, no problem. It's going to circle around and go. But for some reason, ischemia, electrolyte imbalance, we don't know why exactly in this situation, this electrical current is going to come here and it's going to stop. So now what we have is the depolarizing impulses arrives to an area, okay, so it arrives here, and it hits the non-conducting tissue there, and it separates. So the impulse encounters the non-conducting tissue, but because there's also the block, Now what you're going to have is the impulse is going to go down one side. Okay? Now what happens is that the impulse comes down this side, and some of it keeps going. This, there should be arrows kind of going down, but it's going to get here and it's go, wow, undepolarized area. This area hasn't been depolarized because of the block. So it's going to go back around like this, okay? And if it goes back around like this, and this area has repolarized again and is ready to go again, it's just going to keep going round and round and round. This only happens under certain conditions, for example, ischemia, okay? And what we call this is a re-entry circuit or re-entry loop. And the thing that you need to know about these is when these set up, when these re-entry loops are established, they tend to be very fast. So somewhere from 130 to 200, 220, okay? And they also, as they go, they're throwing off an impulse. Okay, so the electrical impulse is going round and round and round, and it tends to throw off these impulses. Okay, so if you think about it, remember one of the things I said is this can be a little tiny thing. So let's say you had a little part of the ventricles where you establish a re-entry circuit going round and round, and every time it comes this way, it throws off an impulse. And let's say it's going around at 190 times a minute, which is possible. What that means is there's a little piece in the ventricle where an impulse is being thrown off at 190 beats a minute, and every time it does, it depolarizes the ventricles. So now all of a sudden you have a very rapid, 190, that's really rapid, that is originated in the ventricles. So it's a bad thing. Okay. So this is not a simple idea. So what do I want you to know from this? Okay. It's not, don't spend time memorizing that precise mechanism, unless you want to, unless you're really interested in it. By all means, knock yourself out. But there will never be a question on a test of list the prerequisites necessary for the reentry circuit, because I don't think you need to have it in your head that pat, in order to do your job. So, but what you need to memorize, what you need to know is reentry circuits are the underlying mechanism of most tachydysrhythmias, and they only exist under very specific conditions. You don't need to know details about the specific conditions. And so our goal with treatment is to shake up those conditions, to stop that reentry circuit. Okay? So, for example, in this particular case, so here's what I was drawing there, is here we have an ectopic focus, or foci, and it's throwing off these abnormal conduction pathways, which is going to lead, in this particular case, to ventricular tachycardia. Okay? There can also be what we think of as macro reentry circuits, where the circuit isn't tiny, it's great big. So the circuit in this case is going round and round the atrium. And that can cause something called atrial flutter, which we're going to talk about later today. Okay, here's another thing you need to know, is that reentry circuits do not start gradually and build up, like sinus tach. If you go outside and you start running, your heart rate gets a little faster, a little faster, a little faster, a little faster. That's not how these reentry circuits happen. They start and stop suddenly. They click into place and then they're broken and they stop. So for example, you can see the underlying sinus rhythm here. There's two normal R to Rs, and all of a sudden, this tachycardia takes over. And you see how it's sudden. It just goes from, 0 to 90, not quite 0, not quite 90, but you get the idea. It just goes normal rhythm, fast rhythm, back to normal rhythm. It clicks in. When those conditions happen, they click in. Okay? And then if here we have a very rapid tachycardia, when they stop, again, they don't stop gradually. It's like we're not quite sure why in this particular case it went back to the original rhythm. Perhaps somebody gave that person medication. They could have shocked them, but there's no sign of shock there. So we don't see it. But again, the reentry circuit, suddenly it collapses, it breaks. Okay, and that's our goal with treatment, is to break the reentry circuit. Okay? Okay. So one more specific thing, and then we'll take a break. Has anybody heard of Wolff-Parkinson-White? Okay. So Wolff-Parkinson-White, named after Dr. Wolff, Dr. Parkinson, and Dr. White, is a congenital defect, if you will, of the heart, where there's an accessory pathway. So instead of just the AV node being the only way to get from ventricles to from atria to ventricles, there's another way. There's another pathway. It's just there. It's a bad thing. People are born with it. And what's really dangerous about it is it doesn't have the pause. It's just a strip of conduction tissue. There's nothing special like it, like the AV node. So it doesn't have the pause. And people who have this will sometimes develop a very large macro reentry circuit that goes down the AV node and back up the accessory pathway. And that one can be really rapid. That can go as fast as 220 beats a minute. And so this is going to lead to a very rapid underlying tachycardia. And we'll come back and talk about WPW later.
No, I just gave it to a nurse.
So, very briefly, we're going to introduce the term SVT. You guys ready? And then we'll really get into it down here. But I want to introduce the term before we actually explain what it is, so you know it's coming. What you need to know about it right now is it's an umbrella term that we are going to start using with atrial and junctional rhythms, because there are 4 different rhythms that we can't tell apart from each other. Just cannot tell apart. They all look alike. And so that's why we're going to start using this term SVT. But we'll pick up on that as we go. So this part should go much faster than the preceding part. We're going to talk about atrial rhythms. So atrial rhythms, Natalie, originate where?
Atria.
In the atria.
Not the SA node.
What's that?
Not the SA node.
Not the SA node. Excellent. And Cody, atrial rhythms are supraventricular, so they almost always have what? Narrow or wide QRS?
Have a narrow.
Okay, except Chris, what's the exception? When would an atrial rhythm possibly have a wide QRS?
Like a delayed, what, like conduction?
Say it again?
Conduction, like a conduction delay?
Yeah, so an interventricular conduction delay, which you can simply say if they have an IVCD, okay? Like a bundle branch block. If an atrial rhythm has a bundle branch block, it's going to have a wide QRS. But because atrial rhythms, the impulse comes down the AV node and gets into the ventricles, we expect for them to have a narrow QRS. So here's the list of atrial rhythms we're going to go through. We're going to do it just like sinus rhythms, in that we're just kind of going to go through them, and then we'll practice. We're not going to have time to do much practice today, but we'll do it next week. And we're going to start with something called a PAC, which is a premature atrial complex. Now, the old term for premature atrial complex is actually premature atrial contraction. So you'll hear about PACs, and if you look in any old reference, it's going to say, in some of the new ones even, premature atrial contraction. Why is that a little bit inaccurate to say when we're looking at a ECG strip and we see a premature atrial beat, to call it a contraction?
Just electric, we're not
Yeah.
treating on the camera.
Remember, it's the same reason why we say that the P wave does not represent atrial contraction, it represents depolarization. Because ECG is just electrical activity, okay? So, anyway, most people just call it a PAC anyway, so it doesn't matter. So a PAC is a single, we've been looking at them all morning. They're those single premature beats that originate in the atria. So the underlying rhythm is usually regular, made irregular by the PAC or PACs. So because a PAC is only a single beat at a time, or occasionally two, it's not applicable. It doesn't make sense to talk about the rate of a single beat. The P waves, the morphology depends on the location of the ectopic focus that causes the PAC. Usually with a PAC, a premature atrial contraction, you will see a P wave and it will be upright. Okay, so it kind of looks like a sinus beat actually. Sometimes you can't see it at all because it's hidden in the preceding T wave. Remember, these things come in prematurely, so they come in right at the end of the T wave, and sometimes the P wave will hit the T wave. Occasionally it's inverted, but we're going to kind of ignore that fact. PRI can range from 0.12 to 0.2. Occasionally it's a little bit less if the PAC is right down near the AV node. The QRS is typically narrow, okay? Now, if the underlying rate, if the normal sinus rhythm, if there's an IVCD, let's say there's a bundle branch block that's widening out the QRS and the normal sinus rhythm, it will also widen out the QRS of the PAC. But we expect a PAC to have a narrow complex. Who's got the pointer? Okay, you want to point to the PAC? Or there are two of them actually. Uh-huh. Yeah, now notice the characteristics. This is this one we saw with a slightly less amplitude. But notice there's a P wave in front of it. It's actually not a sinus P wave, it's an atrial P wave. We know that because it's coming in premature, so it's an ectopic focus. And it's upright. So it's somewhere maybe in the middle, comes from the middle of the atrium. Okay? So now that we know, if you were to see this particular strip, the right answer would be, if I say, what do you see? The right answer would be a normal sinus rhythm with two PACs. And I'm totally happy for you to use the abbreviations, because everybody does. PAC, PVC, PJC. Okay. Okay, you want to, Anne, you want to pass the pointer up, and Kyle, if you can show us this PAC. Yeah, and notice this one's interesting. It's got an upright P wave, but it doesn't look like the sinus P wave. So probably this one is maybe down closer to the AV node, so the shape of the P wave is a little bit different than the sinus P wave. Okay, and Spencer?
That one?
Uh-huh. Now, I'll throw it up to everybody. Is there a P wave there or not?
Yeah,
Kyle?
I think it's buried in that T wave, because that T wave's a little bit taller than the other.
Correct, okay? So you're right, Andrew, we can't see it as such. However, if you look at the size of this T wave compared to the one previous, there's a very good chance there's a P wave, and that's what's popping the T wave up. So we can't actually see it, but it's implied there. We can assume that it's there, okay? So buried P. Okay, etiology, you'll see this list in many references, and caffeine is out of date. It's been shown, I always used to say it, maybe you all have PACs because you're drinking coffee, but actually recent research has shown no, caffeine does not cause premature beats, okay? Typically speaking, by the way, PACs are very benign. You know, if we were all sitting there on a monitor while we're just sitting here, you'd see some PACs floating by. You wouldn't even notice them unless there were a whole bunch of them. They're just a beat that comes in a little bit early. Now, there's something called a non-conductive PAC, okay? So the ectopic focus depolarized the atria, okay? So the ectopic focus, we know it's an atrial ectopic focus because it's a PAC. So let's say that where the ectopic focus, the misplaced pacemaker, is right in the middle of the atria. Depolarizes the atria, and that creates a P wave. But for some reason it gets to the AV node, and maybe because it comes in so prematurely, the AV node is still refractory. And so the impulse comes down through the atria, causing a P wave, but it dies when it gets to the AV node, so there's no QRS. So it's blocked. So what you're going to have is just kind of a little orphan premature P wave. Comes in early, but it's not followed by a QRS. So, for example, what happens with a non-conductive PAC, here's our ectopic focus. It depolarizes the atria, but then the impulse travels to the AV node but does not progress to the ventricles. Okay? And so the ECG is going to show a premature P wave but no QRS. Okay, who's got the pointer? Okay, Riley, where is the non-conductive, the little early orphan P wave?
There.
Yeah, there it is, off the back of the... Now, notice this one is pretty obvious, right? It's there. But it might not be quite that obvious. And if you just glance at it, this, you might say, oh, this is a sinus rhythm, a normal sinus rhythm with a sinus block. But it's not a sinus block. What's happened is that the ectopic focus in the atria depolarized, causing the P wave, and then nothing happened in the AV node. The impulse just died, and it wasn't until the next sinus beat happens that it starts up again. Okay? So be sure when you think there's a sinus pause or a sinus block, be sure to look at the last T wave prior to the pause to see if you can see a non-conductive P wave. Yeah, Kyle.
That PAC would conduct back to the SA node as well, right? And then
Yes.
so it would get that to fire, and then the SA node would restart at that point, right?
Well,
is that what I'm?
I think, again, there's probably a multitude of things that can happen. But I think most likely is you're right, it would conduct back up, and if it's in the middle, it would go down, it would go up at the same time. Which means that the atria around the SA node is depolarized. So it's very possible that the SA node actually fires here. But that because the atria are refractory at that point, you don't see a P wave or a QRS. It just dies in the
I
SA
guess I
node.
was just wondering if you marked out, like with the calipers, that PAC, like your P to P interval from the PAC to your
Is
next
it-
sinus
is it
rhythm
twice?
might be in pace, like.
Yeah, a lot of times it is. A lot of
Okay.
times it is. And there's a term for that. I think it's called a compensated PAC, but I don't teach that because it doesn't matter. But a lot of times it does. It
Okay.
comes right back in, Rich.
Cool.
Which means that if you want to use the 6-second method for this, you can just call this 2 times the R to R interval. Okay. Okay, so COA, where is the non-conducted PAC here?
There's a P.
Yeah. Now, the first one, I think it's fair to say, was pretty obvious, but the second, this one is a little more subtle, okay? And I'm just showing that it's coming in early. So if you march out these P's with your calipers, you can say, oh yeah, it's premature. It's a non-conductive PAC, okay? So if you were to see this one, 10, 20, 30, 40, 50, so this is right on a sinus Brady. So you might say borderline sinus Brady with one non-conductive PAC. Yes.
So let's say that this like pause right here was long enough. Would that be enough for like an escape beat to happen, or would it normally not happen?
Well, yes and no. So, not because of the PAC. It would be unlikely that a PAC would cause, you have to say, well, how come? And occasionally you will see the beat comes, a regular beat comes in on time and it just sort of slips in there. But usually the atria are refractory, so even if the SA node is firing off, you don't get your P wave. It would be, something else would have to be wrong for that pause to go on longer. Either a non-conductive PAC plus a sinus pause, for example.
Okay.
So two mechanisms. Okay. You will hear people say accurately that when you're out in the field, and I'm just going to make up the numbers here so it's accurate but vague, that about 85 to 90% of the patients that you encounter, you put on a monitor, will be in a sinus rhythm. And that's true. Despite the fact we're going to go through all these, for the whole term, these elaborate dysrhythmias, the truth is that most people you see will be in a sinus rhythm. Of that remaining 15 to 10%, again you will hear, about 85 to 90% of those who are not in a sinus rhythm are in atrial fibrillation. And that's also true, okay? So again, 80%, I don't know, I just pulled that out of, the air. But the truth is that most people are in a sinus rhythm and most of the remaining people are in AFib, okay? So it's a very common dysrhythmia, and I'm sure everybody's heard of it, right? Atrial fibrillation, AFib. Most people have some relative who are in it. So what's happening, the mechanism in AFib is many irritable atrial foci are firing off all at once. So what's happening in the atria is just electrical chaos. I mean, just forget about the SA node. It's like outclassed in this case. Just various parts of the atria are just firing off, very, very rapidly, no pattern. That's what fibrillation is. There's no coordinated depolarization. There's no mechanical contraction. Okay, so no mechanical contraction in the atria at all. Okay, multiple impulses are bombarding the AV node. Many. Okay, but remember the AV node can only conduct impulses so fast. So a lot of those impulses will hit the AV node and just die, kind of like waves breaking on a wall. They'll just die. And then every so often one will go through. Only some of those impulses pass through, and when they do, it's in a random pattern. This is the rhythm for which the term irregularly irregular was constructed. Okay? AFib is the classic irregularly irregular rhythm. It's not the only one, but by far, it's the most common one. Okay? So here's just a picture of what's happening. Electrical chaos in the atria, okay, just firing off. A whole bunch of them are hitting the AV node. Only some of them go through. They go through in an irregular pattern. And so what you'll see is an irregularly irregular ventricular pattern. Okay. The other thing that happens is that they're going all different directions, so many of them just don't even reach the AV node. Okay. They sort of bump into each other and die in that way. Okay, AFib. The ventricular rhythm, the pattern of R to R intervals is irregularly irregular. Its rate varies from slow to very fast. Untreated AFib is typically from about 90 to 170, okay? But many times it's being treated as people have are on medication. There are no true P waves. Usually what people use the term, and you don't need to because I don't think it's too useful, they'll call them F waves or fib waves, okay? But not always visible. We're going to look at a whole bunch of AFib all term long, and you'll see what I mean. There is no such thing as a PR interval because we don't have a good P wave, okay? We just have these little fib waves. And the QRS, it's still a supraventricular rhythm. It's still going down through the AV node. So unless there's an IVCD, we expect the QRS to be narrow. Many etiologies. I'll just put this up and you can read through it. Who knows what thyrotoxicosis is? Anybody know? What do you think it involves?
Thyroid.
Yeah, so it's another term for it is thyroid storm. Okay, that's the colloquial term. So thyroid toxicinosis is disease condition of disease. So it's somebody who has untreated hyperthyroidism, leads to all kinds of bad things, not just AFib. Okay, so now I said, you're going to bump into many people who are AFib. How bad is it to live in chronic AFib? Well, one thing, you lose your atrial kick, right? And so I can say for sure, I have no idea who the people in the are here, but I can guarantee you nobody in this picture is an AFib. That being said, it's possible that somebody here is. So there are many people who live in chronic AFib. It doesn't mean they necessarily have a bad quality of life unless they want to be, marathon runners, in which case they're a little bit out of luck. So, but there are some problems associated with chronic AFib. What are they? Who knows? What's the problem with? Excuse me?
Stroke.
Absolutely. Do you know why?
Because since it's fibbing, it's not clearing all the blood out, so it can develop clots inside the atria, and then they'll just go all over the place.
Yeah, excellent, and specifically to the brain. So what's happening is the atria are going crazy electrically, but they're just sitting there mechanically. There's no contraction happening. And so the blood just pools, and when blood pools, it tends to form clots. And especially when you have somebody who goes from AFib into, say, a normal sinus rhythm, all of a sudden there's a big contraction, and it will push that clot out, and it can lead to a stroke. So most people who are in chronic AFib will be on some kind of blood thinner to prevent a stroke. What's another problem? Anybody know?
Well, back to them being on blood thinners when they fall, that's a higher risk for other issues, so it's like a secondary correlation to AFib.
Yeah, you're certainly right. You're absolutely correct when you're thinking of the patient. When you're thinking of AFib, I wouldn't call that correct because, as you say, it's secondary. It's a problem of the treatment, not the AFib itself. But of course, you are right in terms of the patient.
Cardiac output.
Yeah, cardiac output. So, first of all, there's reduced cardiac output. Remember, the atria aren't contracting. That's a problem. Okay, blood pools in the atria, and then the other thing is. Here I have the average ventricular rate is 100 to 200, and I was reading this morning 90 to 170, but whatever, untreated AFib is fast. It's true that, the fib waves can be happening at 600 a minute. Those depolarizations in the atria are incredibly fast, and most of them are not getting through, but even if some of them get through, it's really fast. So untreated AFib, the problem is the rate. And that's what typically when we get called for AFib, when it's too fast. So I would say those are problems. Okay, here's AFib. Again, characteristic of AFib is that it's irregularly irregular. It's random, no pattern, okay? There are no clear P waves. In this case, we see the fib waves, these little bumps, which is helpful, but you cannot depend on the presence of fib waves to identify AFib because they don't always show. So if you're not able to identify atrial fibrillation unless you see the fib waves, if you're expecting to see them, you're going to be out of luck. So, for example, here's another example of AFib, and while it's easy to say the isoelectric line is kind of a mess, it doesn't have those little fib waves. And sometimes you'll see AFib and the isoelectric line will be perfectly smooth. The longer that somebody is in AFib, it tends to remodel the atria, and one of the results of that, and I'm not sure why, is that the longer somebody's in AFib, the fib waves get smaller and smaller and smaller. Okay, so it's very possible to see somebody in AFib with a perfectly flat isoelectric line. So you have to depend on irregular, and no P waves.
Can you go back to the last slide? real
Sure.
quick, please? I missed what you were saying the fib waves are, is that just how?
Oh,
it's really
these
shaky?
are kind of classic fib waves. See how it's like that, okay? Here, you can see, that's the fib waves. What that is the chaotic depolarization in the atria. Yeah.
What about like with Artifact?
Yes.
Reading it isn't
Yes.
that kind of
Yes, it
difficult
does.
to-
Yes, that's the flip side, is you can have a normal sinus rhythm with an isoelectric line that looks perfectly like this.
Mhm.
And unless you're looking closely for the P waves, the regularity versus irregularity, people will call a normal sinus rhythm AFib
Due to that.
because of Artifact. So yes, good, absolutely good point. Okay, when you see this is a term, great if you know it. I don't particularly care. I don't think it's that useful. But you'll hear this. These are coarse fib waves. And you can see why. The amplitude is really big. Again, this is probably fairly newly acquired AFib because that's what it looks like. The newer it is, the coarser the fib waves. There's just a lot of nomenclature that surrounds AFib. Here's another one. AFib with RVR is rapid ventricular rate or rapid ventricular return, which means the same thing. Essentially, it's tachycardic AFib. So typically, over 100, you might call it with RVR. I don't require you to use that terminology. If you want to, by all means, if I say, what is this? And you say AFib with RVR, or tachycardic AFib, that's great. But in terms of just, if I say to you, identify this rhythm, if you say AFib, you're done in my book. Okay? And AFib is perfectly okay. Okay. In fact, a lot of times you'll hear physicians or cardiologists say AF. And I'm actually okay with that too. Okay. Atrial flutter is, remember when we talked about reentry circuits. So what's happened with atrial flutter is a rapid discharge of a single ectopic focus, and it's causing, what happens is there's like this circuit that goes round and round and round and round the atria extremely rapidly, from 250 to 500 times a minute, 300 being sort of the most common of the rates. Only some impulses get through the AV node. They tend to conduct regularly. So let me show you what I mean. Okay, here's a picture. So what happens in atrial flutter is you have a reentry circuit, very rapid. Let's say it's 300 beats a minute, 300 times a minute. And you're going to see, in a minute we'll look at an ECG strip, and there aren't true P waves, but they're what we call flutter waves. And they're about 300 times a minute, so really fast, okay? Every time it hits the AV node, there's a chance of it going down the AV node, okay? But the AV node typically is not going to be depolarized at 300 times a minute. It's too fast. Okay? Let's say that every other time the AV node is ready to be depolarized, what's the rate going to be? Every other time, 300 times a minute.
150.
150. Let's say every third time it hits the AV node, it depolarizes, it's ready to go. 100, yeah. So you get the idea, every fourth time, 75, and so forth, okay? So you don't have to know those are the numbers you already know, but you don't have to know those numbers. I'm only pointing it out to say that typically atrial flutter is regular because what happens is it goes round and round in a regular fashion and it will depolarize every second, or maybe every third, or maybe every fourth. And so a flutter doesn't have to be regular, but typically it's regular. Okay. Another picture. Okay, we'll look at the criteria and then we'll look at some strips, which will make it easier. Ventricular rhythm is usually regular, but occasionally irregularly irregular. We'll look at some examples. The rate can be slow, it can be very fast. The P waves, there are no true P waves. We call them flutter waves, and they're usually at about 300 beats a minute, really fast. There's no PRI because we don't have true P waves. And again, it's a supraventricular rhythm, so usually the QRS is narrow. Same etiology as AFib. Okay, this is what it looks like. So here the flutter waves, and if you look at these typically will line up, let's see if I can find a good one. They typically will line up right on the large box lines. 300 beats a minute, right? Okay, right there, see? There. And then typically they will conduct through at a regular rate. Probably if you took your, if you take your calipers, you'll see this one is pretty regular because it's going through at about every fourth time it goes through. Okay. Here's another one. Some people say they think the flutter waves look like a sawtooth pattern, so if that's helpful for you, you can use that. Some people take the strip, flip it upside down, and it even looks more sawtooth pattern-like. You can try that if it's helpful to you. There is something called atrial flutter with variable conduction, where it doesn't go through at a regular rate. Not nearly as common. So, atrial flutter that goes through every other time is hard to see the flutter waves because you only see like one or two in the middle. If you have, this is just a little helpful thing, if you have a regular tachycardia at 150 beats a minute, think it, and it just stays there, doesn't go up, doesn't go down, just stays there. You should think about maybe it's atrial flutter. So just something to think about. Okay, final note on atrial flutter. You'll see plenty of atrial flutter in this class, but that doesn't represent reality. Okay, I can show you anything I want in any kind of order I want. When you go out and see patients, it's going to be rare to see atrial flutter. It's not very common. You'll see a ton of AFib compared to that should be atrial fib. Atrial flutter is rare. You're not going to see that much in the field. Okay, everybody's favorite, wandering atrial pacemaker, which you really can call WAP. People do, or WAP. Okay. Wandering atrial pacemaker is exactly what it sounds like. The pacemaker wanders all over the place. It might start off in the SA node and fire off a few beats. Then it moves down in the atria and fires off a few beats. It may even go sit in the AV node for a while, fire off a few beats, and who knows, maybe it'll go back up. It just wanders all over the place. And for this reason, the P wave morphology varies. So again, the pacemaker might start off in the SA node, move around in the atria, go down to the AV node, maybe fire off a couple times there, maybe it goes back up again, okay? So, wandering atrial pacemaker, the rhythm can vary. It can be regular, it can be irregular. The rate typically is 60 to 100. It can be slower than 60. That would be more accurate to say less than 100. If it goes over 100, we just call it something different. The P waves vary. That's how you're going to decide that it's wandering atrial pacemakers. The morphology of the P waves changes. The PRI can vary, and it's still supraventricular. So let's look at some. Okay, so if you look, you can see what's happening. This one sort of looks like this one, sort of looks like this one, but then we get a real flat little P wave. It gets flatter, then it disappears altogether. That's probably when the pacemaker has moved into the AV node, and then it kind of goes back again. Okay, so typically we say wandering atrial pacemaker has to have 3 or more different morphologies of P waves, and we've definitely got them. 1, 2, 3, 4, so we've got it. Here's more. Again, it's characterized by weird P waves that change. Okay, so here we have some flat ones that then get bigger and bigger. Okay? So wandering atrial pacemaker, you'll see it in kids, no big deal. It just kind of wanders around a while, sometimes young adults, no big deal. It doesn't necessarily change anything. The ventricular rate is still quite normal. However, there's a version of it that is quite pathological that's associated with lung disease. Okay, almost done here. Multifocal atrial tach, also called MAT, and it's just wandering atrial pacemaker that's faster than 100. Okay? So I'll do, whoops, sorry. So again, all the same. Okay, here's the deal about multifocal atrial tach. It's a really awkward rhythm because you don't see very much of it. So here's some good versions of it. We can see all it has to be is greater than 100, and so this fits the bill, and you can see how the P wave goes all over the place. You can see that? Here's some more. This is all the same. Well, this is the 12 lead. So if you look across the bottom, you'll see how it changes. This one is pretty fast. What is it? It's about 130, 140. Now, here's sort of the bottom line on multifocal atrial tachycardia. It's uncommon. It's not very well understood. Almost all patients who develop multifocal atrial tachycardia, I'm not talking about wandering atrial pacemaker, I'm talking specifically about multifocal atrial tach, are elderly with some kind of respiratory problem such as COPD. It's really weird because it's associated both with lung disease such as COPD, but it's also really associated with a drug called theophylline. Anybody know what theophylline is? It's an old drug. It's not used very much anymore because once we developed albuterol, theophylline has far more side effects than albuterol. So almost everybody's on albuterol, not theophylline. But if you talk to old doctors, they'll say, oh yeah, we used to see MAT all the time. We used to see multifocal atrial tach all the time because people used to be on theophylline and then they would develop multifocal atrial tach. Nowadays, there still are people on theophylline. And nowadays, it's much more rare to have multifocal atrial tach. And like I say, it's usually an old person with lung disease. For that reason, well, let me keep going and then I'll come back to what I was going to say, okay? At rates less than 150, remember all it has to be is above 100. So between 100 to 150, MAT's pretty easy to identify when you can see the P waves, okay? You can see the P waves, pretty easy to identify. It's faster than 100, differing P waves is multifocal atrial tach. However, as soon as it gets really fast, like over 150, it's hard to see the P waves, and multifocal atrial tach looks just like AFib, or can look just like AFib, because you can't see the P waves. The isoelectric line on AFib tends to be real messy anyway, and so it's really hard to tell with atrial from AFib, okay? For that reason, if you're in the field and you have real patients that are in something that you think might be multifocal atrial tach, that's one thing. But in this class, at those rapid rates, just assume it's AFib, because it's not fair to ask somebody to identify multifocal atrial tach without the help of the patient history. And in this class, we just look at strip after strip after strip, with no patient history. So multifocal atrial tach, unless it's like 120, will never be on the test, at least the strip. Yeah.
ECG unrelated, but
Yeah.
would you treat someone in multifocal different,
Yes.
like with drugs,
Than
than you
AFib?
would with someone in AFib?
Yeah, you would. Unfortunately, you would. And like I say, it's really hard to identify. But if you're pretty sure it's multifocal atrial tach, you don't want to shock them, because in many ways it's very simple. Think of it like sinus tach.
Mm-hmm.
In sinus tach, we never shock them.
Mm-hmm.
Okay, and so you treat the underlying cause. If you've got somebody in multifocal atrial tach that's that rapid, there's some underlying thing, like they're dehydrated or something like that. So. Okay. Notes on testing in this class: at rates greater than 150, MAT is very difficult to tell from AFib, especially when there's no clinical picture, which, ECG class, that doesn't happen. So for this reason, while you will be expected to know about multifocal atrial tach, know what it is, know how it's defined, and also I want you to be able to identify it when the P waves are clearly visible, meaning less than 150. I will never put a strip of multifocal atrial tach greater than 140 on a test. Okay? If you see a strip that appears to be AFib with RVR, just assume that's what it is. Don't get all tangled up in multifocal atrial tach. It just complicates life. So, for example, this is clearly multifocal atrial tach because it just looks like a slightly rapid wandering atrial pacemaker. This, if you look at it, you say, oh, are these P waves? Oh, is this multifocal atrial tach? No, this is AFib, but you can see why people get mixed up. So just call this AFib. It almost certainly is AFib. It's AFib in this class. Okay, almost done here, and then we'll go to lunch. So, atrial tachycardia results from an increased automaticity. Okay, you read that. It comes from one spot in the atria. It's very rapid. Here's how we define atrial tach. It's regular. Its rate is greater than 100. It can be really fast, 180, 190, 200. The P waves may be inverted or upright, but typically we do not see the P waves in atrial tach because it's so fast. Typically the P waves are not discernible in atrial tachycardia. Okay? So if there is a P wave, you'll see a PRI, but again, typically there's no PRI because we can't see the P waves if they're there. And then the QRS is narrow. Okay, sort of the usual suspects, why people go into atrial tach. Okay, atrial tach is one of the rhythms that comes under that umbrella term of SVT. This is because it's difficult and impossible to distinguish from these rhythms that we haven't had yet. So next week we're going to talk about junctional tach, AV nodal reentry tach, and AV reentry tachycardia, and they all look alike. This is what they look like, just like this. Okay, this may be atrial tach, but we can't tell. Regular, narrow QRS complex, very rapid, no discernible P waves. Okay, so we have 10 minutes left. Let's look at handout number 2, which starts on page 19, and we're only going to have time to do a few, but I want you to see how using the 5-step process works with this. So who's got the pointer?
I do.
Okay. So I really want you to go through the 5-step process, and you should have your handout in front of you. Don't look up on, because you're going to need your calipers to march out. Is this regular or is it not regular? Page 19.
Page 19.
So Andrew, as you go through it, I want you to verbalize it. So step one, is it regular? And if- okay.
So, no, it's not regular. I see different R to R
Okay,
intervals. Just by looking at it, it does look fast, but I'll.
so if it's now irregular, now is the time, this is when you need to get to the second half of that, is in what way is it irregular? Do you see kind of a pattern, or is it totally random, in which case it's...
Irregularly irregular.
Yeah, don't skip, from now on, never skip that part, because it's gonna really help you, okay? Okay, now rate, let me make a suggestion here. You don't have the marks on it, but that's okay. You can figure the 6 seconds probably goes from about here to about here. And even though it's not regular, use the 6-second method. It's more accurate than the boxes method.
Best guess like 135.
Okay, 135. Yeah, you see, and obviously it's an approximation because it's irregular. Okay, so it's irregular, rate of 135. Now, P waves.
So, I see alternating P waves.
So what are you calling P waves?
I mean, is that more of like those? That's
Okay.
P wave.
So you sort of see P waves, but they look really
They are.
different. So let me suggest to you, these are not P waves, okay? They're, so first of all, when you get to the point of irregularly irregular, this light should flash in your head. Consider AFib, okay? And AFib, the isoelectric line tends to be wild, okay? Lots of fib waves bouncing around. Some of them actually bounce around right in front of the QRS, but there's nothing. I mean, there's no P wave here.
Okay.
I wouldn't call anything here a P
Okay.
wave, okay? So what I would say here is no P waves,
Okay. Okay.
okay? And so that takes you to PRI, and if there's no P waves, the PRI step is super simple,
Non-existent.
non-existent, okay? So then the question is QRS.
So this is AFib.
3 boxes. It's like just about 3 boxes.
Okay, so
AFib.
AFib. This is AFib, yeah, okay? So when you get to irregularly irregular with no P waves, you're almost home free right there. Okay. Okay, Grace, next one, please.
Okay, so we got, okay, question for you.
Yes.
These right here,
Well, let's start step 1. You're going to get there because you're seeing,
okay,
but you don't want to skip those steps.
it looks pretty regular to me.
Okay, and you marched it out and everything. Okay.
The rate was about 70 using the boxes.
Yeah, and I agree. And then you, by all means, use the boxes, but you can also, in this case, boy, we even have the marks for a change, 10, 20, 30, 40, 50, 60, 70. Yeah, 70, 75, good. Okay, now you get to look at the P waves.
Okay, I don't know what's going on right here,
Okay,
because either that's not a P wave or it's inverted.
it's inverted P.
Okay, so you have 1, 2, 3 inverted P waves,
Uh-huh.
so that's already not sinus.
Uh-huh.
And then you have your P waves maybe right here.
Okay, so the P wave morphology changes.
Correct.
And let's just, the PR intervals, let's just finish everything up before you put it all together. PR intervals,
Give me a second.
okay?
Those are 3. Hold on. Psych. Wait, okay, question. These are P's, right?
Yes.
Okay. They are within 3 to 5.
Okay, and then the QRS compounds.
QRS is They are narrow.
Okay. Okay. So everything seems kind of normalish except for those weird P waves. So what's that rhythm where the morphology of the P waves changes?
That is the WAP.
Yes, WAP. Okay. So now let me. I think it's pretty clear to everybody that there's two different morphologies. If you look on the criteria slide, it'll say you have to have three different morphologies, right? And we could argue about, is this a different morphology from this? I don't know. We definitely have two. Do we have three? Point of argument. Here's the deal. You have to have three different morphologies, but you don't necessarily have to have three different morphologies in 6 seconds, okay? So this is wandering atrial pacemaker. It's the thing that makes the most sense, and you know, it could be here or there that you see the third morphology. So don't get too hung up on that three different morphologies. Okay? Okay, so in answer to what it is, it's wandering atrial pacemaker. Okay, Natalie, number 3, please.
Alrighty. So I started with the rate, and I noticed that this looks like a little premature something, and the rest of these are regular. So I found the rate with the, like the small box method.
Okay.
Which is about 90 beats per minute.
Okay.
And then, like I said, there's this premature. The P's are all upright. My PRI interval is between 3 and 5. My QRS is less than 3.
Okay.
So I think it's a premature atrial complex.
Good. Now, if you were to say it's a premature atrial complex, you're right if you're talking about that. Because, by the way, is there a P wave for the
Not
PAC?
Not with the PAC, no. Oh, is there supposed to be? You're asking?
Yeah, there
Depends
is.
on the location of the ectopic foci.
Okay. So I think there is and Andrew is convinced there's a, right, because it was yours before, right? Yeah, so remember that, look at the shape of the T wave, okay? You can see it's bigger. So our best assumption is there's a buried P there, okay? Now, if you look at this strip and you say it's a PAC, I'm gonna say, really? I mean, this one is definitely a PAC, but what about all the rest of it?
So is it like you just say normal sinus
Yes,
rhythm with a
yes.
PAC?
Don't forget. In fact, far more important, to be honest, more important than the PAC is the normal sinus rhythm, as far as the patient's
A PAC
concerned.
is just a type of premature.
Yes.
Correct? Okay.
Yes, we're gonna, next week, we're gonna get another type. In 2 weeks, we'll get the third type. Okay, let's see, let's do 2 more. So Cody, number 4, please.
Yep. Switcher, please.
Oh,
Thank you.
yeah.
So we're gonna start off with the rate.
Okay,
I got,
or regularity.
sorry, regular.
Yeah,
At 80.
okay.
roughly. Looks to appear to have everyone have a normal P wave.
Is it regular? I missed that.
Yes.
Okay.
regular.
Yeah, okay.
Normal P wave. PRI is less than 3.
Okay, less than
Excuse me,
3?
3 to 5.
Yeah,
3 to 5.
okay,
The QRS is less than 3.
okay.
R to R's, what do you say, are all matching?
Regular,
Regular?
yep.
Okay.
Or if you want to be really precise, you'd say the ventricular rate is, if that's all you measure.
Right.
The ventricular rate is regular.
Okay.
Yeah, okay. So put it together, and what do you got?
Normal sinus?
Yeah, this is normal sinus. I'm just keeping you honest, putting a few sinus rhythms in with atrial. Okay, let's do one more, and then we'll call it a day. Chris?
So for 5, this is irregular.
Okay. And in what way is it irregular?
Regularly irregular.
You see a pattern?
I think so.
Okay.
If it was a longer strip, maybe not.
Yeah.
If it was a
you-
longer strip, I could tell. but
Yeah, I agree with that.
It
Yeah.
looks like it's going to be regularly irregular to me.
Irregular or regular?
Regularly irregular. Sorry. Irregular.
Okay, so what, oh, so you think it's going to be like 2 short and 1 long, something like that?
No, it's irregular.
Yeah, we love patterns is the
Yeah.
problem. You know, we always want to see patterns. Go with irregularly, irregular. Yeah.
Irregular. Yeah. Okay, I just lost.
Okay, so what's the rate?
Oh,
And 6 second will work best for you.
you got 7.
Yeah, 70, 75. Yep. And then P waves.
P-Wave's kind of hard to see on this one.
Great.
Honestly, I don't know.
Well, do you see P waves?
I do barely, but
Okay, so I don't. So I don't see, I see a whole bunch of junk, but it's not
not like-
localized in front of the QRS.
Yeah.
So there's just a whole bunch of stuff, but I don't see any specific P waves.
So it's just a flutter.
Well, so it's irregularly irregular, no P waves. What should jump into your head at that point?
Aphid.
Yeah, you'll get it, you'll get it, okay, you'll get it, you just have to keep practicing. Let me tell you one thing though, the slower the AFib, the harder it is to see on the 6 second strip, because you just don't have that many.
Yeah.
Now, I lied, I wanna do one more, Ann, can you do one more, because then because that's,
Okay, that looks regular,
uh-huh,
and the rate is about, a little more than 100.
okay.
Um,
150, yeah, over 100, yeah, okay.
I would not say those are nice P waves.
Not nice, they're awful people.
You're a bad
And then, so for PRIs, not obtainable. QRS complex is normal and narrow.
Okay,
So, I think this is, sinus tachycardia atrial flutter.
okay, so, if you drop the first 2 words and kept the second 2 words, you'd be accurate.
Okay.
So you can't, so think about it for a minute. The first term tells you where it originates. It can't originate from the sinus node MA2, okay? And so this is atrial flutter. Now, here's the deal with atrial flutter is that it's, in my book, it's one of the few rhythms where the 5-step process only takes you so far because you have to be able to recognize flutter waves. There's no 2 ways about it. You just have to be able to recognize them. And the way that you recognize them is look at a bunch of them. Okay? Okay, so here's what we're going to do is, as part of your homework this week, and it's on the to-do list, I want you to go through some of the atrial rhythms in the workout book. Just really work on it. Next week, we'll begin by finishing these atrial rhythms and a few more so that we feel pretty good about the atrial rhythms before we move on to the junctional rhythms. Yes, Kyle?
For that A flutter, is that a 4-to-1 conduction ratio?
Ooh, let's see, 1, 2, 300, 150. I actually think it's 3 to 1. So, one of the sneaky things about A flutter is they tend to be upside down.
Okay.
So it's like 1, 2, 3. The other thing is, the rate is about 100, and so that, I actually think it's easier to use the rate than the time of the waves, because the waves are very confusing about how they line up.